Coming up in this episode, when do you switch to systems 2 thinking? So, this is when the constellation of symptoms and signs is unusual in some way, or there's something just not quite right about the case, or to be colloquial, your spider senses are tingling, and you just have a feeling that there might be something rare or hidden at play. The diagnosis isn't immediately clear to you. This is the sign to slow down. Hello, and welcome to the next installment of Neurology Education, a not for profit, free open access project with a philosophical touch exploring all areas of clinical neurology. For medical students through to neurologists and any health professionals caring for patients with neurological conditions. Welcome to 2026, and I'm really excited to present a really interesting episode today, which I've been really waiting for the opportunity to do. And it's titled Diagnostic Reasoning 101, Generating a Differential Diagnosis in Medicine and Neurology. And it's part of the Clinical Method series. Now, I'm Tom. I'm a neurologist, epileptologist, and neuromuscular physician, and also a physician, philosopher, bioethicist, and medical educator. And the last 3 episodes that we did, they were all journal club episodes, which were targeted at some of the more senior audience members, so neurology trainees and neurologists. But I really wanted to go back to basics today. So we're going to be looking at how do you generate a differential diagnosis? How do you perform diagnostic reasoning applied to medicine and also specifically applied to neurology? So this should hopefully be really good for the medical students in the audience and also some of the more junior doctors in the audience. But hopefully everyone, including some of the more senior practitioners, will derive value from this episode as well. A legal disclaimer: the content of this episode is for educational purposes only, and also any post-publication corrections which I do occasionally come across will be included in the video and audio written descriptions. And again, I'm recording on a weekend, so I'm in my casual t-shirts, and this one is one of my favorite paintings by my favorite artist, Rob Gonzalez. So if you like modern surrealism and magical realism, then definitely check out Rob Gonzalez because he's fantastic. So let's dive into it. Basically, the way to think about it is that there are 2 types of thinking, which has been described as the dual process model of thinking. And this applies to general medicine and to all subspecialties within medicine, and it also applies to neurology. So you've probably heard of this concept before. There's systems 1 thinking and systems 2 thinking. So systems 1 thinking is fast, intuitive, automatic, effortless. And so this is a heuristics-based approach. So that's a rule of thumb approach, and it's founded on pattern recognition. And really, this is mainly for senior or experienced clinicians who have built up a big history of patients that they've seen in the past so that they can rely on the patterns that they can see in patients they've seen previously. And so this can be applied in some circumstances, not all circumstances, but some circumstances. Conversely, systems 2 thinking is your slow, deliberate, attention-demanding, effortful thinking, and it's used for complex problem solving and conscious reasoning. So this is recommended for especially more junior audience members, so medical students and more junior doctors who haven't yet built up that massive past patient base and are not yet able to see patterns in a database that hasn't been built up yet. But also it applies to any difficult case, and that's for everyone, including senior physicians. And that's really important. You need to know when to use each one. So it would be completely exhausting to use systems 2 thinking exclusively in your daily clinical practice because it just wouldn't be sustainable. The cognitive load would be through the roof. You'd burn out and you just wouldn't be able to see patients quickly enough either. So you just wouldn't have the throughput necessary to meet the demands of the health district that you're working in. So when can you use each one? Systems 1 is appropriate if you've seen hundreds of similar cases, and with the case in front of you, there's nothing abnormal about it, there's nothing unusual about it, and basically you can tell what the diagnosis is, or at least the few main differential diagnoses and exactly how you need to proceed appropriately after you've heard the first couple of sentences of the clinical vignette as if it was an examination question. So sometimes you might receive a phone call and you listen and the person starts talking and you think to yourself in the first minute, I already know what this is or what this probably is, and I know what the appropriate steps of action are. So that's when systems 1 thinking is appropriate. And sometimes that's what you like because it doesn't have the same cognitive demand. Sometimes, for instance, if you're in the lab in a neurophysiology clinic, sometimes it's nice just to have a few straightforward carpal tunnel syndromes and you can do them on semi-autopilot. And then you've got the cognitive reserve necessary when you have a difficult query ALS case or a query plexopathy case that requires a lot of higher order reasoning to nut out. Then systems 2 thinking. When do you switch to systems 2 thinking? So this is when the constellation of symptoms and signs is unusual in some way, or there's something just not quite right about the case, or to be colloquial, your spider senses are tingling, and you just have a feeling that there might be something rare or hidden at play. The diagnosis isn't immediately clear to you. This is the sign to slow down, and you need to then adopt proper methodical diagnostic reasoning approaches, and that's going to be the content of the rest of this episode. And of course, complex cases always fall into this category. So these are usually the sorts of cases that end up as case reports and grand rounds presentations. And if things go astray, then they're the cases that end up getting discussed in M&M meetings, morbidity and mortality meetings. So when is each system appropriate with some examples? So here are some examples of where systems 1 thinking is appropriate. So you have a patient, and to use an example that's been used many times before, you have someone with sudden severe central crushing chest pain radiating to the left shoulder, and they're a vascular path with the full house of metabolic risk factors, as I like to call them. So the full house is 5 cards, and you've got your 5 main metabolic risk factors: diabetes, obesity, hypertension, dyslipidemia, and smoking. And this patient had an acute myocardial infarct 2 years ago. They have known high-grade LAD stenosis, and you know that they've been not adherent with their aspirin, and the person calling you says, we've already done an ECG and it shows some anterior ST elevation, and their high sensitivity to troponin I or troponin T has come back at 20,000, and we've done a bedside echo and it shows some anterior wall hypokinesis. So this case is not a case that requires any degree of higher order diagnostic thinking or reasoning. You don't need to sit down and open up the textbooks for this one. This is clearly an anterior STEMI and it requires quick action. So you need to aspirin load the patient, then you need to revascularize, so PCI, percutaneous coronary intervention, if it's available at your site, otherwise thrombolysis. You need to load with a second antiplatelet of choice, depending on the revascularization choice. So when I was doing cardiology back in the day, I don't know if it's changed now, but back in the day, a few years ago, if the patient was going for PCI, we'd load with ticagrelor, whereas if they were being thrombolyzed, then we'd load with clopidogrel. We'd also anticoagulate in the emergency department with 5,000 units of intravenous unfractionated heparin as the patient is going to the cath lab. And then they'd get admitted to the coronary care unit after the percutaneous coronary intervention. They get a formal transthoracic echocardiogram, telemetry. Then you turn to secondary prevention. So you add in your beta blocker, you add in your statin, you add in your ACE inhibitor or your angiotensin receptor blocker, lifestyle intervention, etc. So this is a case in medicine outside of neurology where systems 1 thinking is entirely appropriate. Now, what's an example in neurology where systems 1 thinking is appropriate? So suppose you had a patient with a diarrheal illness 3 weeks ago, and now they have a rapidly progressive numbness and weakness, which is ascending from their toes bilaterally upwards over a course of 2 to 3 days. And now they've got some early difficulty breathing as well. And on examination, they have widespread hyporeflexia or areflexia. So again, you don't need to scratch your head and sit down and open up the textbooks for this one. This is GBS, Guillain-Barré syndrome, until proven otherwise. And this clinical vignette is strongly suggestive of AIDP subtype, so the acute inflammatory demyelinating polyradicular neuropathy subtype. And so this patient clearly needs an urgent lumbar puncture to look for an elevated protein and albuminocytologic dissociation, ideally a nerve conduction studies if you have access to them. They need frequent spirometry for a forced vital capacity monitoring. You need to pre-notify the intensive care unit in case the patient needs to go to ICU for pulmonary intervention, mechanical ventilation, and the like. And assuming that the investigations that you've done in an emergent fashion are concordant with the diagnosis, and they need urgent commencement of treatment if it's a severe case, as this one sounds to be, usually with intravenous immunoglobulin, IVIG, or sometimes with Plex plasma exchange. Now, What about systems two thinking? So suppose that you have built up a database of hundreds of patients you've seen in the past. When should you swap from systems one thinking to systems two thinking? Well, basically, it's any scenario, really, any scenario where the diagnosis or the required course of action is not immediately and automatically clear. So if we just modify the previous examples to twist them a little bit so that bits of it don't fit, and so we need to switch to systems two thinking. So in the chest pain example, what if actually the chest pain was a tear in character and radiating through to the back, and on examination you thought maybe there was some radial delay? Then you should think, maybe this isn't just a garden variety acute coronary syndrome, maybe this is actually an aortic dissection. Before I give the aspirin, maybe I'll do a CT aortogram ASAP. And to alter it a little bit more, you might see this on a gastroenterology rotation or on a cardiology rotation. What if the patient has central chest pain, but there's also a bit of vomiting, maybe some hematemesis? What if the patient's looking still and pale? Then maybe they'd be on an upper GI bleed pathway, or maybe still a chest pain pathway, but maybe something like an esophageal rupture or a Boerhaave syndrome would be a consideration. So you might think, again, this doesn't sound like a typical acute coronary syndrome or just a typical bleeding peptic ulcer disease or a typical variceal hemorrhage. Maybe we need to do some imaging of the esophagus. And then perhaps it turned out to be a Boerhaave syndrome on the CT chest, and so you get an upper GI surgical consultation, start some broad-spectrum antibiotics for the associated impending mediastinitis. So there are two examples where you need to switch from your systems one thinking to systems two thinking because something just doesn't quite fit in those examples. And I chose them because they're probably my two most clutch diagnoses that I made in my pre-neurology days. A bit of an odd flex there, but there was one case when I was doing cardiology when I just thought, this just doesn't seem like all the acute coronary syndromes I've seen over the last 3 months. We should image this patient for a dissection, and they had one. And then on a gastroenterology rotation, I had this young guy, and he just didn't look like all the upper GI bleeds I'd seen in the preceding 3 months. He looked like he was about to die. He was pale as a ghost and tripoding and drooling, and just thought that it didn't look like a classic peptic ulcer disease, and we imaged and he had a Boerhaave syndrome. So that's when systems two thinking really kicks in. Now let's change the neurology example we gave to explain where systems two thinking needs to kick in. So in the previous Guillain-Barré syndrome example, what if the tempo was a bit off? So it was a bit too slow or a bit too fast? Or what if the anatomic pattern wasn't quite right? What if it was highly asymmetrical? Or what if the reflex findings didn't quite fit? Then you might need to think of, or you would in fact need to think of alternative diagnoses. Could it be a stroke? Could it be a cord syndrome? Could it be a different form of neuropathy? Could it be multiple lesions? And the reason I bring this example up is I had a case recently a few months ago, which was mimicking Guillain-Barré syndrome, where I received the call saying it was a Guillain-Barré syndrome, but it just didn't quite fit. The signs and the tempo just didn't quite fit. And on a careful examination, the patient actually had some dissociated sensory loss. So on one side of the body, they had spinothalamic tract loss, so temperature and pinprick. And then on the other side of the body, they had their proprioception and vibration sense loss, so their dorsal column loss. And there were also reflex asymmetries, so they were hyporeflexic in some places, but they actually had upper motor neuron signs with some upgoing plantar on one side. And so I thought, this just doesn't fit. So that's when you have to go beyond your systems one thinking into your systems two thinking. And this patient actually ended up having a hemicord syndrome, so a Brown-Séquard syndrome from a probable inflammatory or neoplastic cord lesion, so an inflammatory or a neoplastic myelitis, myelopathy. And this was superimposed on a completely unrelated subacute underlying peripheral neuropathy, which hadn't been diagnosed. And that's what really complicated all the signs and threw everyone. So there is one other type of thinking which I would like to suggest. This isn't a term that's been coined elsewhere as far as I'm aware, but it is a helpful way to think about things. So is there a halfway house? Is there something in between systems one thinking and systems two thinking? What about a systems 1.5 thinking, for example? So what I'd like to propose is that systems 1.5 thinking is kind of like a heuristic-based short list of the key differential diagnoses that you need to consider in any particular clinical scenario, which is quick and efficient, but it's not completely automatic. And it's a good compromise often. So rather than having one or two differential diagnoses or 20 or 30, what about if you just had 5 or 6 of the key differential diagnoses you need to think about that cover 98% of the cases you're going to see in real life? So, two good examples for this that I've used in my head. I haven't seen this written down anywhere, but for chest pain, when I'm asked to see a chest pain consult previously, I think, well, look, what are the main life threatening causes of acute chest pain to consider? And I think about the rule of twos. So, I think there are two main cardiac ones, two main vascular ones, two main pulmonary ones, and two main other ones, whereas the other ones are way less frequent. So the two main cardiac ones are an acute myocardial infarction, so an acute coronary syndrome, or say a pericarditis with tamponade that can be very fatal very quickly and it can cause acute chest pain. The two vascular ones are a dissection, so an aortic dissection, or a pulmonary embolism. The two pulmonary ones are a pneumothorax or plausibly a really nasty pneumonia. And the two other ones are a gastroenterological one, a Boerhaave syndrome, and then a hematological one, a sickle cell crisis. And I can't say I've ever diagnosed a sickle cell crisis, so that's why they're in grey if you're watching in the video here. Now, of course, this is not an exhaustive list of causes of chest pain. I'm sure that you can open the books and you can find other causes of chest pain that aren't on this list. But it's just a helpful shortcut way of thinking about it when you get the page or the code blue and you're walking to the emergency department or the ward for the chest pain consult for the patient who's unstable, and you think, what are the main things I need to not miss and think about quickly here? Well, I need to think about acute coronary syndromes, pericarditic problems and tamponade problems. I need to think about aortic dissections, PEs, pneumothoraces, nasty pneumonias, and then that's going to address the life-threatening causes of acute chest pain 99% of the time. And of course, if it's not fitting into that and it's not looking like any of those, then you switch to your full-on systems 2 thinking. But it's just a starting point. The other example of systems 1.5 thinking that I'd like to propose is what are some of the causes of anemia? So again, there's heaps of causes of anemia, but let's apply the rule of twos again. So I like to think of two main microcytic causes of anemia, two main normocytic causes of anemia, and two main macrocytic causes of anemia. So your microcytic ones are your iron deficiency anemia and your thalassemias. Your normocytic ones are your anemia of chronic disease. That can be microcytic as well, but I'll put it in the normocytic category. And acute blood loss, so not chronic blood loss, which has resulted in iron deficiency, but acute blood loss. And then your two main macrocytic ones are B12 and folate deficiency and alcohol. And again, of course, this is not an exhaustive list. And if there's a hematologist listening right now, they've probably just had a stroke listening to me say this. But of course, it doesn't address many things. It doesn't address hemolytic anemias. It doesn't address hematologic malignancies with cytopenias and blast crises, etc. But using this rule of twos, you will get to the answer with this system most of the time, and you'll be able to tell very quickly if it doesn't quite fit. So if you have a microcytic anemia and it isn't an iron deficiency anemia and you've done hemoglobin electrophoresis and it's not a thalassemia, then you think, well, I need to think more broadly then. Let's go to the full-on systems 2 thinking and think about what else could it be. Or if you have a macrocytic anemia and they're not B12 or folate deficient and they don't have a problem alcohol use disorder, or if it's a normocytic anemia and it's not just an anemia of chronic disease or an acute blood loss, then that's when you think, well, okay, we've ruled out those common ones, let's think more broadly. So you just need to use it appropriately. So onto systems 2 thinking, which is what I want to focus on for the rest of this episode. So this is combining an etiological or pathophysiological approach and an anatomical based approach. And that also includes a consideration of the tempo, particularly in neurology. It applies to everything, but especially in neurology. And then by tackling the problem from these two different angles, so the etiology and the anatomy, you can then narrow in on what the diagnosis is or what the couple of differential diagnoses are. So in terms of the etiology, you may have heard of the concept of a surgical sieve, and that's basically an acronym of different etiologies. The two main ones that I've come across are Vindicate and vitamin C, and you may have come across them in the past. Personally, I don't like them because I don't think they're comprehensive enough, so I've made my own, and that's what I'm really excited to share with you this episode, and that'll be on the next slide. But if you don't like mine, you can just use Vindicate or vitamin C. It will get you to the same place. The other point to remember is that in order to generate a good output, so the diagnosis, you need to have the right input. So that means having a thorough and accurate history and examination, as well as having a good diagnostic reasoning process. So you could have a really good diagnostic reasoning process, but if you're starting from the wrong starting point, so if you have the wrong input, so if you think that the patient has vertigo, but you took a bad history and it was actually syncope or pre-syncope, or if you think the patient has upper motor neuron signs, but you did a rushed examination and you misinterpreted that and they actually had lower motor neuron signs, it doesn't matter how good your diagnostic reasoning is, you're going to get the wrong diagnosis because you had the wrong input. So basically, crap in equals crap out. So you need to have good diagnostic reasoning, but you also need to have a good history and a good examination and a good input in order to get a good output. So hopefully you've had a chance to, or if you haven't, please do check out the other episodes on risk of neurology education. So the history episodes and the examination episodes, so that you can get really good at those core fundamental clinical skills to get good input. The other thing that you need is you need to have a good knowledge base of all the various conditions, because otherwise you just have too many unknown unknowns. So, for example, you couldn't possibly diagnose allergic bronchopulmonary aspergillosis, ABPA, if you've never heard of that condition and you didn't even know that that condition existed. Then how can you possibly diagnose it? So the three things you need good history taking and good examination skills to get a good input of data. You need a good diagnostic reasoning process. And unfortunately, you do need to have a good knowledge base of the various conditions as well, because you can't diagnose something that you've never heard of. So, what is this coveted, patented acronym that I've been telling you about? So, you're probably going to think that I'm completely crazy and that I have two heads, but this is it. It is: how nice is it now that Daniel Evans pours cream in icing? Doesn't make a lot of sense, but it's just an easy flowing sentence. So I'll say it again. How nice is it now that Daniel Evans pours cream in icing? So you can probably guess what this stands for some of them at least. So the H is for hypoxic, and I'm going to include vascular and hemorrhage there as well. It's all got to do with blood vessels, right? The next one, the N, is for neoplastic, then infective, then immune, then nutritional, toxic, degenerative, endocrine, physical, congenital, iatrogenic, and idiopathic. So you can see how this is more comprehensive than vitamin C or Vindicate, which have fewer letters in them and they don't address all of these categories of etiologies. So I'll just say it one more time. How nice is it now that Daniel Evans pours cream in icing for hypoxic, neoplastic, infective, immune, nutritional, toxic, degenerative, endocrine, physical, congenital, iatrogenic, idiopathic? And you may notice that the way that this has been ordered is not random. It's been arranged roughly according to epidemiological factors. So how frequently are you going to come across these different etiological categories when you're making diagnoses in hospital wards and in the emergency department and in your outpatient rooms? And I've organized it so that the key players are up the top and the less frequent ones are a bit further down towards the bottom. Of course, this depends on what specialty you're working in. If you're an orthopedic surgeon, then you probably put physical towards the top, wouldn't you? But it's just a bit of a rough attempt at ordering it in a sensible way. Now, it can be broken down further, and this is where you get a bit more meat on that initial skeleton. So for the hypoxic category, which includes vascular and hemorrhagic causes as well, that includes thrombosis and embolism, dissection, and also insufficient oxygenation. So that could be from pulmonary problems or ambient environmental problems of reduced oxygen in the environment, or from reduced cardiac outflow states, and that could then result in a type 2 ischemia pattern. So you could have an end organ which isn't getting enough oxygen and suffers from ischemia, but it's not because the blood vessel feeding that organ has had a thrombosis or an embolus or a dissection complicated by thrombosis or embolism. It might just be that the patient's really hypoxic because they are being drowned, or they're in acute pulmonary edema, or they have a bad pneumonia, or they have heart failure and poor cardiac output. And so you might get type 2 ischemia in that end organ, such as in the heart or watershed strokes, etc. Then neoplastic, so that of course can be broken down into primary and secondary. And then primary can be further broken down into solid organ and hematological malignancies. Then infective, there's a few ways you can think about this. So I like to think about the pathogen types. So bacterial, there's 7 of them: bacterial, viral, fungal, protozoal, helminthic, arthropod, and prion. So they're the 7. You can also think about different routes of exposure, and you can also think about opportunistic infections in the context of immunocompromised hosts. Then immune, you think about this one in terms of deficiencies and excesses. So you can have an immunodeficient state, or you can have various forms of excessive immune state. So you can have autoimmune conditions or autoinflammatory conditions, and also allergy. Then nutrition, you also think of in terms of deficiencies and toxicities or excessive states. So you can have a nutritional deficiency, or you can have a nutritional excess or a toxicity. And then you also need to think of your nutrients as your micronutrients and your macronutrients. So that makes a bit of a 2x2 grid. So for instance, you could have a vitamin B12 deficiency, or you could have a vitamin B6 excess, or you could be obese because you have a macronutritional excess, or you could be malnourished because you have a macronutritional deficiency. Then toxic is broken down into 2. So you've got drugs, which can be either prescribed or recreational drugs, and also poisoning. And we'll put in envenomation there as well, especially because I'm Australian and from Australia, you've got to have envenomation on the list. Then degenerative, that doesn't have any further subtypes. Then endocrine, so this can be, again, a hormonal deficiency or a hormonal excess. And there are various hormonal axes that can be considered. So you've got your HPA, your hypothalamic pituitary adrenal axis. You've got your thyroid hormone axis. You've got your gonadal hormone axes. Then physical, there's a few subcategories here as well. So firstly, you have trauma, which the orthopods are going to be interested in. Burns, and then also I had to squeeze this one in somewhere. So physically occluded pipes, and what I mean there is renal colic or biliary colic. So if you have nephrolithiasis or cholelithiasis or choledocholithiasis, so you've got a stone that's blocking a ureter or a gallbladder or a common bile duct, then I've put that in the physical category. You're physically blocking an internal structure. Congenital, you can think about this in terms of genetic or non-genetic, but still congenital by nature of it being perinatal. And then genetic, of course, can be further broken down. So it could be mitochondrial, could be non-mitochondrial, could be autosomal, it could be sex-linked, and then different patterns of inheritance. And then metabolic conditions are often genetic as well, with some overlap there. Then iatrogenic speaks for itself, and idiopathic speaks for itself. And I have just put in a little subpoint there that many conditions in neurology do fall in the idiopathic category. For instance, not all, but many epilepsies turn out to be idiopathic. So that's also something not to forget about. I will acknowledge that there is a bit of overlap potentially between some of these etiological classes, but I've designed it so that there's as little overlap as possible, and a bit of overlap's okay because we're aiming for comprehensiveness here, not brevity. So we've addressed one side of the puzzle. What's the other side of the puzzle? So it's the anatomy. What are the anatomical systems that could be implicated here? Well, all we need to do is think of our functional anatomy, system space. So you've got your neurological system, cardiac, vascular, pulmonary, alimentary, hepatobiliary, renourinary, if you allow me to make a word up, reproductive, blood lymphatic and splenic, musculoskeletal and rheumatological, and dermatological. And again, these can be broken down into more detail. So for neurological, you can think about all the steps in the neuraxis, so the central nervous system and the peripheral nervous system. So you've got your cortex, then your subcortical structures, your white matter tracts, your deep gray matter structures, your gray matter nuclei, the cerebellum, the brainstem, then you've got your spinal cord, the nerve root, the nerve plexus, the peripheral nerve, the neuromuscular junction, and the muscle. And then if we include some of the special sensory organs as well, you've got the eye, so your ophthalmological system, and then that can be further broken down, of course, into cornea, conjunctiva and sclera, iris, lens, the vitreous with the anterior and posterior chambers, retina and its subparts, and then also your auditory apparatus, your olfactory and gustatory special sensory pathways. Then for cardiac, that can of course be broken down into the coronary arteries, the conductive pathways, the heart valves, and then each of the 4 heart chambers themselves, or the different layers of the heart, so the endocardium, myocardium, and pericardium. For vascular, obviously there's some overlap with what I've just said, but you can have your systemic circulation or your pulmonary circulation, and also your portal circulation, or it can be broken down into large and medium and small sized blood vessels, especially arteries, or it can be broken down into arteries versus veins versus capillaries. For pulmonary, anatomically, you've got your nose and mouth, your pharynx and larynx, your epiglottis, your trachea, bronchi, bronchioles, alveoli, pleura. For alimentary, you've got your mouth, pharynx, esophagus, stomach, your duodenum, so D1 through 4, jejunum and ileum, so the small bowel, then your large bowel, so your cecum, and we'll throw the appendix in there, the ascending, transverse, and descending colon and sigmoid colon, and then the rectum and anus. For hepatobiliary, you've got your liver, your gallbladder, your biliary tree, and your pancreas. For renourinary, you've got your kidneys, and I like to break them down further into glomerular, tubular, and interstitial components of the kidneys. Then you've got your ureters, your urinary bladder, and your urethra, and that fits in nicely with the pre-renal, renal, post-renal paradigm that people think of. And the reason I think about glomerular, tubular, and interstitial in terms of the kidney microanatomy is they're the parts of the kidney that can go wrong in terms of the intrinsic renal causes of an acute kidney injury. Then reproductive, so of course you've got your male and female primary and secondary sexual organs. For your blood, lymphatics, and splenic system, it's already in the name. For musculoskeletal and rheumatological, you have your bones, your cartilage and joints, your ligaments, tendons, muscles. And then finally, dermatological, there's skin, including all the exocrine glands and the sensory organs contained therein, and hair. So we can take a deep breath for a moment. So how do we put it all together? So for a truly undifferentiated problem where you don't know what body system is involved and you don't know what the etiology is, you could theoretically draw a 12 by 11 table. So you could have the x-axis or the columns for the etiology and the y-axis or the rows for each of the functional body systems. And then you'd end up with a table with 132 cells in it. And then you could literally write every single diagnosis in Harrison's in this table if you wanted to. Obviously, this process is way too time-consuming in reality, and I've never actually done this, but it does give you a way to think about how you might go about generating a comprehensive differential diagnosis in clinical practice. So I've done it here just for the sake of illustrative example if you're watching along on the video form of the episode. So here's the table with the columns as your etiological categories and the rows as your functional anatomical body systems. In reality, based on the presenting symptom or symptoms, you usually know which organ system or 2 or 3 organ systems might be at play. So you can really narrow it down immediately. And so what I usually actually do in practice is I just run through the etiological categories. So I run through that acronym. How nice is it now that Daniel Evans pours cream in icing to think about what could I be missing here? And every organic diagnosis in existence should be able to fit into this table. So it really is a comprehensive way of thinking about diagnoses in clinical medicine, although it doesn't cover psychiatry. So how do we apply systems 2 thinking specifically to neurology now? So firstly, we need to think etiologically as previous, and this is where tempo really, really, really helps in neurology. So tempo gives you your biggest hint at what the etiology is. And then you also need to think anatomically, but supposing that we've narrowed it down to the neurological system at least, you then broke it down further, so into the different parts of the neuraxis and the peripheral nervous system that I mentioned previously. And you also have to take into consideration some other important anatomical patterns. So you have to think, is it a unilateral problem or a bilateral problem? Is it symmetrical or asymmetrical? Is it affecting the upper limbs and or the lower limbs? Is it a motor problem or a sensory problem or mixed? Is it sensory motor? And another way that you can think about it, which is different, but it's a different way of doing the same thing, is you can think about the different subspecialties within neurology as a similar proxy framework. So you can think headache medicine. Oh, could this be a primary headache syndrome, which is the diagnosis, the cause of my patient's symptoms? Or if you're thinking about a movement disorders clinic, could this be a Parkinson's plus syndrome? Or if you're thinking about cognitive neurology, you might think, oh, could this be a variant of primary progressive aphasia? The other thing is in neurology, sometimes the diagnosis ends up being functional or psychiatric. So you can just add a single cell, not a row or a column, but just a single additional cell for a functional or psychiatric cause of the problem. Now, in reality, this is usually a diagnosis of exclusion with supportive additional positive features in order to make a diagnosis of a functional condition. People always say these days functional neurologic disorder or functional symptoms or psychological or psychiatric problems are not just a diagnosis of exclusion. I think honestly, you've got a strong case to disagree with that. I think it really is largely. So in a case of the GBS patient before, you're not going to ever say, oh, this motor and sensory problem is functional until you've excluded the dangerous organic problems that could kill the patient. So you do need to think always, what are the organic problems that could be very harmful to my patient, and have I excluded them all? And then what's left over, could this be functional? But I will completely agree and emphasize that functional neurologic disorder and functional symptoms are not just a diagnosis of exclusion, because there are absolutely important positive features that allow you to substantiate a diagnosis of functional neurologic disorder and then explain that to the patient. And that's essential in terms of making an accurate diagnosis and also essential in developing a good therapeutic relationship and getting positive management outcomes. But it really is that dual process of excluding organic problems and then also positive supporting factors for the diagnosis. What else do you need to do in neurology in Systems 2 diagnostic reasoning? Well, you need to determine, is there one lesion or are there multiple lesions? And you also need to determine whether this is a single system problem. So is this just a system problem of the neurological system? Or is it a multi-system problem? So, for example, could it be a systemic vasculitis or a systemic lupus erythematosus or a disseminated thromboembolism from infective endocarditis throwing off emboli all over the shop to the spleen and the gut and the brain? So they could manifest with both neurological and non-neurological problems. So this is just demonstrating that applied specifically to neurology, you can use the same approach with a table, but keeping the columns the same, so your etiological categories, but you change all the rows. So instead of starting with neurological and then going to cardiac, pulmonary, etc., you just replace that with the parts of the central and peripheral nervous system. So you just start with cortical and then work down to subcortical, white matter tracts, deep gray nuclei, brainstem, so that's your midbrain, your pons, and your medulla. Then you also have your cerebellum, but I'm going to group them all together just so it fits in the table nicely. Then spinal cord, nerve root, plexus, peripheral nerves, neuromuscular junction, and muscle. And it fits into the table just like before. And then adding in one additional cell just for functional or psychiatric. And just like we could fit all of Harrison's into the previous table, for this table, we can fit all of Bradley and Darraf's, or all of Adams and Victor's, or all of Merritt's, or all of the Queen Square Neurology textbook into this one table. So you're not going to miss anything if you think in this way. Now, just a little more about the tempo. So as I mentioned before, tempo really helps determining the etiology. And that's basically the same thing as the what is the lesion question that you would have heard of. It helps enormously. So let's break this down. We can break it down into hyperacute, acute, subacute, and chronic. So hyperacute, by that I mean we're talking a time frame of seconds to a minute or a couple of minutes. And if that's the case, so if something's coming on so quickly, then you've got to think hypoxic, including vascular and hemorrhagic as well, or physical trauma. Then if something's acute, so there we're talking hours to days, you've got to think infective, you've got to think immune inflammatory demyelinating, and you've got to think toxic. If something's subacute, and by that I mean weeks to months, 3 to 6 months or so, you've got to think neoplastic, nutritional, endocrine. And if something's chronic, by that I mean more than 3 or 6 months, then you've got to think degenerative or congenital. Now, of course, there is some overlap in the adjacent steps in the above. So a cause of acute could also appear hyperacute or a subacute could appear chronic. You get the idea. But that's the basic way to think about it. And of course, it is just a rough rule of thumb, and there will be some exceptions, but it's very, very, very helpful. And I cannot stress this enough. So just very quickly again, hyperacute seconds to minutes. Think along the lines of vascular, hypoxic, hemorrhagic, and also physical trauma. If it's acute, so hours to days, think along the lines of infective, immune, inflammatory, demyelinating, and toxic. If it's subacute, so weeks to 3 or 6 months, think neoplastic, nutritional, endocrine. And if it's chronic, so more than 3 or 6 months, think degenerative and congenital. What else do we need to think about? So I said before, other important distinctions are between unilateral and bilateral, symmetrical and asymmetrical, and upper and lower limbs. So these are anatomical patterns that are important. And they help enormously with anatomical localization. So that's the where is the lesion question, not what is the lesion, where is the lesion? And they're the two things that you need to bring together and marry. Now, in order to do this, you need to know your functional neuroanatomy. You don't really need to know it at kind of the relational neuroanatomy, neurosurgical level, because unless you're a neurosurgeon, you're not doing the neurosurgery, but you need to know how the system works. And then putting that in clinically, you need to identify patterns such as a hemiparesis versus a monoparesis versus a paraparesis versus a quadri or tetraparesis. And of course, you can substitute in sensory for paresis weakness in all of those limb combination patterns as well. Then you need to think about motor problems versus sensory problems versus mixed sensory motor problems. If it's sensory, you need to think what modality is involved. Is it spinothalamic, or is it dorsal columns, or is it both? You need to then think what other parts of the neuraxis are involved. Is there any ocular involvement or not? Is there any bulbar involvement or not? So is there a problem with speaking and swallowing? Is it symmetrical or not? And then you put it all together. So in the previous example of the run-of-the-mill Guillain-Barré syndrome that I gave at the beginning, in that example, we had a fairly symmetric, bilateral, sensory motor problem with lower motor neuron signs. So that already suggests that this is a peripheral neuropathy, which is the cause of this problem. So that's the where is the lesion question. Then the tempo, so the acute time frame suggests that this is an acute polyneuropathy, and specifically it suggests that it may be, say, an immune, inflammatory, demyelinating type of problem. And then some additional factors, so the ascending nature, the widespread marked reflex loss, the pulmonary involvement, the recent diarrheal illness. So that's what really pins down, they're the additional icing on the cake that really pins down the diagnosis of Guillain-Barré syndrome as the diagnosis, and probably AIDP, so acute inflammatory demyelinating polyradicular neuropathy, specifically as the diagnosis. The last thing to say here is that anatomically, if a single lesion can explain all of the symptoms and signs, then that is probably correct, according to the theorem of Occam's razor. So if you had a diagram of the central and peripheral nervous system on a piece of paper, and you could get a pen and just do a little cross of one little part of that nervous system, and with that one little cross, you could explain all the symptoms and signs with one lesion, then according to Occam's razor, that's probably where the lesion is. Not always, but probably. Conversely, if you can't just do a little cross and knock off one little part of the nervous system and explain all the symptoms and signs, then you might actually be dealing with multiple lesions. And we do see this in neurology. So a good example would be you could have multiple embolic strokes, with the previous example of the patient with infective endocarditis throwing off emboli all over the place. That could be throwing off some strokes to the left hemisphere and to the right hemisphere and to the brainstem. And so you could get a bit of a hot pot of symptoms and signs on both sides of the body and a bit of a scattered multifocal distribution that doesn't fit one lesion. And that can actually be a hint in and of itself to the diagnosis. So if you ask the question, where is the lesion? So the anatomical question, and it looks like it's multifocal, then that actually really narrows down the differential diagnosis. So that's quite helpful. Another example would be the altered version of the Guillain-Barré case that I gave previously. So in the case of the underlying undiagnosed peripheral neuropathy with a superimposed myelopathy. So that's two different lesions which are not related in any way, or unlikely to be related. Maybe they were remotely related, but two completely different conditions that together explain the combination of symptoms and signs. Whereas in that case, there wasn't really any one single lesion in one part of the nervous system that could have sensibly explained all of the symptoms and signs that were being seen. So this is the last slide. I'd just like to do a summary slide just to try and bring together everything that we've learned today. So it's always good to generate a differential diagnosis, focusing on the most likely differential diagnoses and also some of the less likely but important not to miss dangerous differential diagnoses. Sometimes system 1 thinking is appropriate. And the time that that's appropriate is when the clinical vignette that's being told to you over the phone or that the patient is telling you when you say, so what symptoms do you have? Why are you here? When the clinical vignette immediately gives away the diagnosis or at the very least, a clearly appropriate course of investigative action that you need to undertake, that's when systems 1 thinking is appropriate. And I haven't said this yet, but it's also very appropriate in various emergency situations. So of course, we have our highly, highly practiced and semi-automatic thinking in a resuscitation setting, just following doctors ABCD. And in stroke calls, if you listen to the stroke call episode that I released a few months ago, you have a very structured way of approaching a stroke call so that you don't need to drop onto the floor in a blubbering mess and you can just fall back on your highly practiced semi-automatic way of approaching a stroke call. And the other thing I'll say is that the more experienced you are, that means you've had more patient encounters and you've developed a bigger database, so to speak, of patients in which to see patterns. So you can then do your pattern recognition more effectively. And so you have more opportunity for systems 1 thinking. So you can do systems 1 thinking more frequently, and that can increase your efficiency, decrease the cognitive demand, and it can increase your patient throughput. So you can just get through more patients more efficiently. Conversely, when you're more junior or when you're just starting out, you won't have built up this database over years and years, so you'll have to use systems 2 thinking most of the time. But this is actually a good thing, and it's really important because this is how you learn how to think critically and thoroughly, and importantly, it's how not to miss things. And for everyone, especially senior doctors, you need to know when to switch from systems 1 thinking to systems 2 thinking. And the time that you do that is when something just doesn't fit, something just doesn't seem right. There's a piece of information, such as a symptom or a sign or an epidemiological factor that just doesn't add up. And that's your red flag warning to say, stop, Tom, I need to slow down and think a bit more critically and deliberately and broadly about this clinical problem. And this is when you then dive into your etiological framework in a deliberate, conscious way. And just remember, how nice is it now that Daniel Evans pours cream in icing for your etiologies, and you pair that, you marry that up with your functional anatomical systems, so all of your body systems, if you're outside of just doing subspecialty neurology, or if you're just doing neurology, then breaking it down into the neuraxis, the steps of the neuraxis and the peripheral nervous system. And then you combine this with your knowledge of the tempo and other anatomical factors such as laterality, symmetry, motor versus sensory motor, the presence or absence of ocular and bulbar involvement, whether other non-neurologic systems are involved or not, in order to then land on the diagnosis, or at least to come up with a short list of differential diagnoses and therefore a sensible plan in terms of the next steps to take with investigations and empiric management. So that's all I had for you today. Thank you so much for tuning in. I really hope you enjoyed this one because this is obviously a very fundamental and very important episode. So I hope you learned something from it. Please do like, comment, and subscribe. And I will say, when I'm watching YouTube and I hear other people say, please like, comment, and subscribe, sometimes I think, oh, why would I do that? That couldn't be that important to the person. But really, it's the way that the algorithm means that Restored Neurology education gets picked up and recommended to other people so that other people can see it as well. It's really the only way that I have to try and grow. So I would really appreciate it if you liked, commented, and subscribed. Visit our website, rneurologyeducation.org, for all our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms, all at the domain at @neurologyeducation. Or email us on contact@rneurologyeducation.org with any questions, or to subscribe for updates when new content is released. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.